A specific kind of panic sets in during a medical board exam. You have less than 90 seconds per question, and the clock is ruthless. In that minute and a half, you are expected to correctly categorize a dizzying array of hematological anemias: thalassemia, spherocytosis, pernicious anemia. The list of overlapping symptoms and specific lab values can feel endless. So, when a study hack surfaces promising a diagnostic shortcut, it spreads incredibly fast across medical school study groups and online forums. The framework we are looking at today claims you can categorize all major anemias purely through a 3-step physical exam, entirely skipping blood investigations. The appeal is obvious. It promises to take a massive, tangled web of diagnostic lab values and compress it down into a straightforward yes or no checklist. To see if this strategy is safe, we must contrast a doctor's 2 environments. On the left, the exam room, a time-constrained world with textbook symptoms. On the right, the clinic, a high-stakes environment where real patients present complex, atypical profiles. This leaves us with a critical choice. Is this no investigation heuristic a brilliant way to save precious time, or a dangerous oversimplification that guarantees a misdiagnosis? We are going to systematically stress test the 3 steps of this algorithm to see exactly where it succeeds and exactly where it falls apart. Because the true value of any medical shortcut depends entirely on whether your goal is passing a standardized test or keeping a human being alive. Before looking at the specific diagnostic steps, it helps to remember that anemia affects the entire body systematically. A lack of healthy red blood cells starves tissues of oxygen from head to toe. This flowchart tracks the first step. An enlarged spleen, or splenomegaly, equals hemolytic anemia. Brilliantly simple for test-taking and pattern recognition on board vignettes. But clinically, an enlarged spleen takes time to develop. Early-stage cases often present with a normal-feeling abdomen. If you skip the lab work simply because the spleen feels normal, you generate a dangerous false negative. That delays specialist referrals and leaves the underlying destruction of red blood cells completely unchecked. So, what happens if the spleen is normal? The algorithm moves to step 2. The flowchart expands downward. We check for neurological manifestations, like numbness. If present, the rule dictates megaloblastic, or B12, anemia. This identifies severe, late-stage cases for test writers. But clinically, relying on this is dangerous. Neurological damage is often an irreversible consequence. When the myelin sheath protecting the nerves degrades from lack of B12, the resulting nerve damage isn't an early warning sign, it is a sign of systemic failure. Waiting for a patient's nervous system to start failing before you initiate diagnostic labs ensures they suffer entirely preventable harm. Applying these first 2 steps in an actual clinic forces a physician to operate backwards, relying on dangerous end-stage symptoms rather than proactive early detection. If a patient has no enlarged spleen and no nerve damage, the algorithm offers one final failsafe: checking for unique physical signs. This final causes the fingernails to grow in a hollow, spoon-like shape. These signs sound definitive, but to evaluate their true clinical value, we have to look at them through the metrics of sensitivity versus specificity. Specificity is a test's ability to correctly identify those without the disease, which keeps false positives to a minimum. Sensitivity is a test's ability to correctly identify those with the disease, which minimizes false negatives. Look at this quadrant mapping diagnostic speed against accuracy. The unique signs point drops aggressively into high specificity, low sensitivity. Specificity is high. A dirt-eating patient certainly has iron deficiency. But sensitivity is catastrophically low. Modern patients rarely exhibit these extreme symptoms. In modern clinics, typical iron deficiency presents as invisible, generalized fatigue. You cannot see it. You have to run a basic blood panel to detect it. This exposes the false economy of the entire hack. The mental energy you save by not ordering a lab is eclipsed by the weeks lost treating a misdiagnosed patient. Relying on unique physical signs as your primary diagnostic tool guarantees you will completely miss the most common type of anemia walking through your door. When we step back and evaluate the entire 3-step physical exam framework, its proper place in medicine becomes clear. Clinical heuristics are tools of rapid triage. They are designed to point you in a general direction, not to establish definitive truth. We can determine exactly who should use this tool and when by looking at this comparison matrix. Let's start with the medical board exams row. Memorizing this decision tree allows you to rapidly eliminate incorrect multiple choice answers based on a few buzzwords. For students, this is an acceptable trade-off. Temporarily suspending complex clinical reasoning is necessary to handle the sheer speed required to pass the boards. That results in a verdict of high utility and low risk for test takers facing classic exaggerated vignettes. But mapping the real-world clinic row tells a different story. Skipping a basic complete blood count and a blood smear yields almost zero upfront time-saving benefit for the physician. The trade-off for doctors is unacceptable. Bypassing labs introduces massive medical legal risk and jeopardizes patient safety by ensuring you missed early-stage and atypical presentations. The severe textbook presentations this hack relies upon are medical relics. They rarely walk into modern medical facilities unchecked. Saving yourself a minor amount of cognitive effort is never a valid justification for bypassing standard of care laboratory testing. So here is the definitive rule. Use simplified physical heuristics to form your initial clinical suspicions, but rely strictly on laboratory data to finalize your diagnosis.